negative behaviors triggers the excretion of endorphin, leading to a sense of elation. And negative emotions can intensify range of health threats, stress, anxiety, and depression. And negative emotions can intensify range of health threats, contribute to prolonged infections, delayed wound healing, or as perpetuating elevated pro-inflammatory cytokines. So psychological therapies or strategies in the treatment of diabetes. So there is a pressing need for the development and implementation of effective, well-evaluated psychosocial intervention and therapies to assist patients dealing with the all-day challenges of diabetes, psychological screening and management at every level of diabetes care. It is crucial to sensitize healthcare professionals, patients with the diabetes, and their family members. So we need to have a family decision making. We need to provide proper education, motivation to the entire family members regarding the significance of psychological screening as well as intervention along with other recommended treatments. ADA position statement advocate screening during the initial visit at periodic intervals whenever there is a change in disease condition, treatment, or lifestyle circumstances. These best practices are often overlooked in clinical settings due to various reasons, mainly lack of time and resources. So the therapeutic approach on primary two modalities, psychosocial support, psychopharmacological agents. So we have guidance on self-care, cognitive behavioral therapy, social supportive networks, psychopharmacological agents, and recommendations for clinical practice. Conclusion. The relation between diabetes and psychosocial disorder is multifactorial. The emotional and psychological requirements are often undermined. Addressing the psychosocial needs of the patient would help improve health outcomes, better glycemic control. It is important to address mental health systems in a consistent and ongoing manner as part of diabetes treatment. So before I conclude my talk, let me invite all our delegates to register for this conference, 53rd annual conference of RSSDI, that is going to be conducted in Kochi from November 6 to 9, and please make yourself available and make this a memorable and a successful event. And of course, for the postgraduates, we request you to participate in this quiz competition. Thank you very much for your kind listening.
At the end of all the three is a good friend, Dr. Anil Virmani. Anil Virmani will be speaking on trusted spaces as gateways to diabetes prevention. Something interesting. The topic itself is very interesting, gateways. So let us hear to Dr. Anil Virmani and learn something.
Good morning to all of you, Honorable Chairperson and dear friends. At the outset, I would like to thank the Dr. Velu and the Dr. Vijay Kumar and the entire team of TRAC for inviting me here today. My topic today is trusted spaces as gateways to diabetes prevention. No disclosures. Now, this is one of the largest epidemiological studies ever done in the world from Dr. V. Mohan Center, the ICMR in-depth study, and it showed that the prevalence of diabetes has almost stabilized at around 10 to 11% throughout the country. If you look at the IDF Atlas 2025, there are more than 89.8 million patients with diabetes, and India has the second largest number of adults. But what is more frightening is the prevalence of pre-diabetes, which is more than 15%. Now this brings us to the multi-million-dollar question: is it time to focus on the prevention of type 2 diabetes? Friends, and there's a wonderful paper, a consensus statement from Ramchandran et al., call to action for clinicians in the Southeast Asian region on primary prevention of diabetes in people with pre-diabetes. Let me summarize this paper for you. It basically prioritizes prevention and calls this a window of opportunity where we can prevent diabetes. Screening and early diagnosis to identify individuals at risk, personalized interventions based on the needs of each patient, national programs for prevention, management, and surveillance, addressing social and economic disparities, recommend strategies for integrating diabetes prevention into public health systems, empowering clinicians by providing practical guidelines which can be implemented in the primary prevention program both at the individual and community levels. Focus on Southeast Asia because this is the one where we are facing the tsunami. If you look at strategies for primary prevention, we all know mass awareness and education program all of us are doing. Screen in early diagnosis all of us are doing. But where we are stopping is identification of high-risk patients and risk stratification, which is very important. Now, lifestyle intervention is the most important part or the pillar of prevention of diabetes. And that is basically behavioral modification, which is the center stone of prevention. And they have non-pharmacologically, the mobile health or M-health has shown to facilitate this sustained behavioral changes with a wider reach, utilizing less manpower, time and cost. And then of course we have the pharmacological, metformin is the only one that has been approved by the US FDA for the prevention of diabetes, but we have other two drugs, the pioglitazone and SGLT2 inhibitors, which have a very high potential, and we need more work and data on that. But remember, prevention is as crucial as treatment in combating the diabetes epidemic. Now, why prevention needs a new approach? We all know how to prevent diabetes, but we are not approaching it the right way. Despite all our efforts, diabetes continues to rise globally, and India is the top affected. Prevention efforts often miss the most at risk due to mistrust in the healthcare system. We must admit today that there is a lot of mistrust in the healthcare system. There are access barriers for the patients, it may be geographic, socioeconomic, language, or culture. And what are the strategies to overcome these barriers? Community-based outreach, that is the most important thing. This can help build trust, improve access to services. Culturally competent care by training the healthcare providers to be culturally sensitive and aware of the needs of diverse populations, and this can improve interactions and build trust. Addressing the stigma and working to reduce discriminatory attitudes can create a more inclusive and supportive environment for individuals who are seeking care. Expanding access to services by providing affordable, accessible healthcare services, including telemedicine, mobile clinics, and this can overcome geographic and financial barriers. Promoting health literacy, which is very, very important. It is an educated man or educated patient is the one who can be easily treated. In various formats and languages, going to the patient's own language to enable individuals to make informed decisions about their health. So the core thing that message I want to give you is building community-centric, inclusive, and impactful health engagements by using trusted spaces which offer a transformative opportunity. Now you may wonder, what are these trusted spaces? These trusted spaces are nothing but physical or social environments where individuals feel safe, respected, and heard. And these are the community centers, the faith-based institutions like the church, temple, gurdwaras, and so on, local pharmacies, schools, women's help groups. The key trait of all these things is that there is familiarity, there is cultural alignment, and non-judgmental atmosphere. And all these are very, very important. So why trusted spaces matter in the prevention of diabetes? As I earlier said, that behavioral modification is the most important thing if you want to prevent diabetes. The power of trust in health behavior cannot be underestimated. Patients who trust their doctors heal faster than those who do not trust their doctors. Trust builds engagement and adherence. Easier acceptance of screening, education, and lifestyle changes. Reduces fear, stigma, and resistance to medical interventions. We have been telling our patients to go for doing walking, yoga, and all that, but none of them used to listen to us. and Baba Ramdev came, and even the Prime Minister was doing yoga with him. So where was it? It was nothing but trust. There was mistrust in the healthcare system, and he was trusted. So people listened to him. Community-driven prevention models. There are real-world examples. The DCLIP study, where it was the lifestyle intervention was led by community workers. Faith and Diabetes program in the US, where churches are delivering the educational programs, and local self-help groups in rural India. Now let me talk about the DCLIP randomized control trial. Again, from South India, they are doing excellent work. And this is the Diabetes Community Lifestyle Improvement Program, randomized control trial in 578 overweight, obese Asian Indian patients with isolated fasting, isolated impaired glucose tolerance, and combined impaired fasting and impaired glucose tolerance in Chennai. And they were basically testing the lifestyle prevention measures. And what they did, they had community-based recruitment and randomized to standard lifestyle advice control for a 6 months period, culturally tailored US diabetes prevention program based lifestyle curriculum. And what did it emphasize? Weight loss, improved nutrition, and increased physical activity. And look at the dramatic results of the DCLIP study. There was a relative risk reduction of 32%, and the number needed to treat one case was only 9.8. Now, of course, there was a difference between who got the maximum benefit. Patients with impaired fasting and impaired glucose combined got 36% relative risk reduction, whereas patients with impaired fasting glucose got the least 12%. And it was stronger in patients 50 years and older and male or obese patients. And 72 patients required addition of metformin. So we must remember that isolated impaired fasting glucose may require some other intervention, and lifestyle intervention may not work in these patients. Then the other is the church-based program in the US. This was in New Dawn in North Carolina, a Diabetes Awareness and Wellness Network. And this was conducted among 24 churches. Participants were enrolled at each church, randomized as a unit to either special intervention or minimal intervention. There was individual counseling visits, 12 group sessions, 3 postcard messages from the participants' diabetes care provider, and 12 monthly telephone calls from a diabetes advisor or counselor. And this was nothing but a family model diabetes self-management education and support using church as a media. And this covered topics like healthy eating, physical activity, blood glucose monitoring, medication management, and problem solving. And they could prevent diabetes in a lot of patients. So what are the components of a trusted framework? Trusted spaces. We have to build a framework. Culturally competent educators, peer support systems, accessible and convenient locations, consistent presence, not episodic. It's not that you do a camp once a year and forget about it. Embedded digital tools like telemedicine, mobile health apps, and so on. So all this have to be used. What is the role of technology? Blending trust with innovation. Telehealth kiosks in temples or schools. There can be a small room-like thing where people can go and get advice or counseling. WhatsApp-based follow-ups by local health workers. Almost all of us are reading a WhatsApp daily. Artificial intelligence-powered risk scoring through community surveys. Digital nudges in native languages, sending patients messages in their own languages where they'll be easily access to it and be able to do it. And we need to have policy and program implications. There should be a partnership between the government and the non-governmental organizations, like we have the National Non-Communicable Disease Control Program. Training of ASHAs, accredited social health activists, and the auxiliary nurse, the ANMs in diabetes education, because they are a key component of the National Rural Health Mission in our country. And corporate social funding for community-based screening camps. These are very, very important if we want to manage it. And inclusion of Ayushman Bharat wellness centers. Now there are challenges and safeguards, and it is very important to address privacy concerns in tight-knit communities where they don't want outsiders to come in and interfere with their daily work. Avoiding misinformation from informal channels. We should give them. It should not be from the